Thank you very much, and thank you very much for the invitation. It's been fantastic traveling around this beautiful city, and like Ajay, I think the history of Krakow is pretty incredible and pretty amazing, and I've been here literally a day and less than a day, but it imbibed so much, so thank you for having me over. What I am going to do over the next half hour or so is kind of give you a basis on what we do for bone disease, but hopefully turn this into more of a practical approach as to how you take care of people with myeloma-related bone disease. And obviously this audience doesn't need a backdrop on myeloma and the significance of myeloma, but the important thing to remember is myeloma is a continuum of diseases. We've already pointed out that this tends to be a very heterogeneous disease, but Ajay has pointed out the precursor disease state for myeloma, which is smoldering myeloma, and a lot of exciting work is happening in that space as well. We tend to treat myeloma when it becomes symptomatic, and symptomatic is when you actually see clinical effects of myeloma. There's several different organ systems which are impacted. All of you know about what happens to the blood system or the hematopoietic system with low blood counts, circulating immunoglobulins, etc. The kidneys are obviously at a huge risk in patients with myeloma, and at the outset, at the time of presentation, it's anywhere between 20 and 30% of people who will have some amount of renal insufficiency. And if you follow patients long enough over the course of a patient's myeloma's life, it can tend to be more than 50 or 60% of our patients can have significant renal dysfunction. And obviously bone disease is something which is really impacted in, I will argue and say, in 100% of multiple myeloma patients. And the question is really, how hard do you look to evaluate the bone disease? And if you look hard enough, you are going to find some derangement in bone metabolism in almost all patients with multiple myeloma. So what happens with myeloma bone disease? And you know, the bone is in fact probably one of the most dynamic organs in a human body. It is an organ which is constantly modeling and remodeling, so that when you look at a normal bone, you have two sets of cells, the osteoclasts and the osteoblasts. These are the bone resorping cells and the bone forming cells. And all of you are familiar with what happens in the state of multiple myeloma, where you have increased amount of osteoclastogenesis and almost no osteoblastogenesis, or even if osteoblasts do exist in myeloma cells, we now know with studies both in the preclinical setting is the fact that the osteoblasts are not quite functional. So there is no new bone formation happening. And what you see in myeloma patients is an extreme form of osteoporosis resulting in osteolytic disease. Over the last few years, my lab has focused a lot on trying to understand the interaction of the tumor cell with the bone-forming cells. We've also appreciated and understood the interactions of the stromal compartment of the myeloma cells. And up until recently, I think we've done a lot of work with myeloma in relation to the osteoclast, very little work in terms of osteoblasts. But I will say that over the last 3 and 4 years, I think this has been of great interest to me in the lab, and we're trying to move this forward to the clinic as well. And I do think trying to target these pathways are going to be a game changer in the future in multiple myeloma. As far as myeloma-related bone disease, all of you are familiar with skeletal surveys. We do x-rays on every patient with myeloma, and myeloma is classically defined by this pathognomic lytic bone lesions because of the increased osteoclastogenesis that I just mentioned. And this slide was shown to you by Ajay already. What's happened over the last 3 and 4 years is we've redefined myeloma, redefined it by some of the new diagnostic criteria, the ones being the most important ones being the bone marrow plasmacytosis and serum-free light chains. But along with that, we've also redefined how you look for bone disease, so that you cannot stop at that skeletal survey that I just showed you. If a skeletal survey of a patient with a paraproteinemia is completely normal, it is recommended that you do an MRI or a PET scan or a CAT scan. And if you have disease on that more sensitive imaging, whether they are symptomatic or not, that is defined as an organ-defining end organ damage in myeloma, and that would in fact be reason to treat a patient with myeloma. So the new definition for bone disease has included a lytic lesion on radiography, CT scans or PET CT scans, and a focal lesion on an MRI of more than one focal lesion should be considered for treatment of myeloma. What we've started doing at Mass General now have given up on using skeletal surveys, because skeletal surveys really pick up disease in only about 60 or 70% of myeloma. And it's important for you to understand and appreciate the fact that you need to have lost about 50% of your bone mass to be able to see an abnormal skeletal survey. So the bone disease is pretty advanced. So what have we resorted to? We're doing these whole body low dose CAT scans. These are actually extremely user friendly. They give you a little more radiation for sure, but not as much as with a dedicated CAT scan. And you are able to look at all bones here, and the sensitivity of a whole body low dose CAT scan is as high as 90%. So you're going to be able to pick up disease in 90% of patients. The other important thing is, unlike a skeletal survey, which can take a lot of time and you have to position a patient for every different long bone to x-ray, this is a 1 minute, 1.5 minute in the tube and out of the tube. So from a patient standpoint, it's quite convenient. I think we in the United States are still struggling with insurance covering us completely, but we are publishing more and more guidelines as to incorporating this, and including in the ASCO guidelines as well as NCCN guidelines, so that this can now be routinely used, because this should in fact be used for patients with myeloma. What about other imaging technologies? So I tend to use, I'm just going to say a quick word on PET CT scan before we talk about MRIs. I tend to use a PET CT scan mostly in patients who are oligosecretory or not producing a lot of myeloma protein and have macrofocal or extramedullary plasmacytomas. In those folks, I think doing a PET CT scan is extremely useful. It can be used to also document response. In terms of MRIs, MRIs can give you a lot of information, and the places where it can give you information obviously is if patients have cord compression, it's very easy to pick up. I don't necessarily do it to look for focal lesions, because a CT scan can actually pick it up quite well. But anytime you have issues, especially in an older woman, so women in their 70s, if they have a monoclonal protein and they have osteopenia on a DEXA scan and they have a compression fracture, which you do not think is related to myeloma, using an MRI of the spine can actually help you discriminate between an osteoporotic spinal fracture versus that from myeloma, because in multiple myeloma you're going to see this very heterogeneous appearance in the bone marrow, which you will not see in patients with osteoporosis. So it tends to be useful in certain situations for sure. We've also started doing whole body MRIs now. At least at my institution, it's still a research tool, and all of these imaging modalities tend to be fairly expensive. So I think it's important for us to appreciate where and when you should be using them and not necessarily using them indiscriminately. So what have we done in terms of treatment of myeloma? Well, we've been using bisphosphonates now for many, many, many years, more than 40 years of experience with bisphosphonates, and they're still here to stay. We are doing more and more in terms of surgical interventions, so vertebroplasties, kyphoplasties, and at my center. It's the interventional radiologist who tends to do this. We're using radiation therapy less and less frequently, and I think that's a good thing, because I think it's really important for you to think long and hard when you're using radiation treatment, because radiation can impact blood counts of a patient. It can cause thrombocytopenia, can cause low blood counts, and that then can preclude a patient from going on to other systemic treatments. And obviously, I think the most important thing for bone disease is treatment of the underlying multiple myeloma itself. This is data with bisphosphonates. All of you are familiar with this. This was comparing Pamidronate to zoledronic acid. No difference in terms of reducing SRE rates. Whether you use Pamidronate or zoledronic acid in this equivalence trial. So up until this MRC data came out, we were using, and even today actually, we use either Iridia or zoledronic acid for the treatment of myeloma. This study, the MRC9 trial, was a study wherein the bone treatment was essentially piggybacked onto their ongoing MRC9 trial, which included several different arms, and I'm not going to go into the details of that those, because end of the day, I think what MRC9 really learned of was bone disease. And in my mind, it's so important, and to me this trial is so instructive, is because this treatment was slapped onto an already existing large clinical trial. There was no bias seen in other characteristics, and it was not just treated as supportive care, wherein we could really start seeing differences. I will argue and say that here zoledronic acid was compared to Clonal. We could never have done this trial in the United States. Clonal is certainly inferior to zoledronic acid, undoubtedly, but in the UK, this was allowed because Clonal is an approved treatment for the treatment of bone disease. And I think the few important take-home points from this MRC9 trial is the fact that whether you have bone lesions or not, treating with a bone-targeted agent once you've committed a patient to treatment for myeloma is important, because even in patients who did not have lesions at baseline, zoledronic acid was protective and prevented the development of further osteolytic disease. What it also showed was new osteolytic lesions were decreased, whether they had intensive treatment, that is transplant, or no transplant, and the only discriminating factor here was zoledronic acid versus Clonal, and most importantly, there was a favor in terms of overall survival in patients who got zoledronic acid versus those who got Clonal. Obviously, when we use these bone-targeted agents, the problems you have with these are things like osteonecrosis of the jaw. This is a patient of mine, and this is the site of ONJ. This was the place where he had an infected tooth. Tooth had to come out. What you see here is a bridge, and this is essentially what ONJ looks like. Another less talked about complication of these bone-targeted agents is stress fractures, and we are beginning to see more and more of these. This was not in a myeloma patient, but I do have patients with multiple myeloma where you get stress fractures of either the femur or in fact also of the metatarsal, and you tend to get them with very little trauma, and typically if you do imaging, you're going to see that there is no real bone lesions there. So it's not because of myeloma, but it's because of the bone-targeted agent that we've been using for years. And this I view as more of a good news problem. I think we see these problems only because our patients are living as long as they're living, and only because we're giving them treatment for as many years as we're giving them treatment. So we went ahead to try and figure out what was the underlying cause of all of this disruption in bone metabolism, and we looked specifically at ONJ patients. This was just peripheral blood mononuclear cells, where we did gene expression profiling now many years back, and what we found was that the biochemical and gene expression profiling studies suggested that in addition to osteoclasts, which are obviously suppressed quite significantly with these bone resorption agents, we tend to suppress the already suppressed bone anabolic effect, which is the bone forming cells, which is osteoblasts, and that creates such an imbalance which causes what we refer to now as ONJ, or even the same pathophysiology, I think, exists for stress fractures as well. We then went ahead and did a biomarker study. This was a study done in a small subset of patients, only about 30 patients. And what we did here was these patients were all on maintenance treatment. So they've had about 4 to 6 doses of their zoledronic acid or Pamidronate. Following that, we gave them 1 dose of zoledronic acid and then stopped treatment and followed their biomarkers, that is, followed their N-telopeptide levels. And what we were able to see was that the numbers of N-telopeptides started rising around month 3 or so in the majority of patients, and this correlated, at least in one patient, with the existence of bone disease, suggesting again that one can use biomarkers, but these biomarkers have to be used once you've stopped these bisphosphonates, but also, most importantly, suggesting to us and instructive to us in that you can use these bisphosphonates less frequently, and you do not have to be using them monthly, once a month, forever. So based on that, we did what is known as the ZMARC study. The ZMARC study was a study with 121 patients wherein we used N-telopeptide, which is the marker of bone resorption. And if the N-telopeptide was suppressed or less than 50, we gave everybody zoledronic acid every 3 months. If the N-telopeptide was above 50, we gave these patients monthly zoledronic acid. And what you see out here is initially we had a few patients where the N-telopeptides were up, but once they were started on zoledronic acid, everybody went down below the 50 threshold, and in the majority of patients, we were able to switch them to zoledronic acid every 3 months. What we saw here was in these 121 patients, 117 of them, that means the majority of them, we were able to keep on every 12 weeks of zoledronic acid, so giving zoledronic acids every 3 months. We did switch about 38 patients back to Q monthly zoledronic acid, and the most important reason for that was a predefined indication in the protocol suggesting that if a myeloma patient progresses, they should be getting monthly, and that was the majority of patients. And there were about 5 patients who developed skill-related events over the course of the first year. It was 7 patients, course of the second year, 5 patients. And this, I think, is the longest trial. So these were patients who'd had up to 2 years of a bisphosphonate, and then we gave them for an additional 2 years. So this is on an average 3 to 4 years. Of this, the risk of ONJ here was about 4 patients in this 121, so about 3.6% or so, which is in keeping with literature. What it also taught us that you can use zoledronic acid every 3 months, and at least in my practice, I tend to use that. We did not find using N-telopeptide on a longitudinal basis that useful, because you cannot have a pre-specified time to do N-telopeptide levels, but you, in fact, because you can never really predict when that SRE is going to happen. And, you should be testing for N-telopeptide, if at all, around a skeletal-related event. The risk of ONJ was also low once you decrease the frequency of zoledronic acid use. So what have we learned from bisphosphonates? They inhibit bone resorption. Both Pamidronate and zoledronic acid are equally good. Zoledronic acid is the only one which has shown a survival advantage. And at least as of right now, the belief is that you can use less frequent dosing of zoledronic acid. What about other targets for bone disease? And all of you are familiar with rank ligand, and in fact, rank ligand and the biology of rank ligand has best been studied in myeloma. And this is myeloma bone marrow samples from a patient. These are myeloma cells which express a lot of rank ligand, very little OPG, and it's converse in a patient who has normal plasma cells. What was unfortunate was an old study which was done in myeloma patients. Now, this was not a myeloma specific study, but myeloma patients were added on to a solid tumor study which included kidney cancer patients, lung cancer patients, and thyroid cancer patients. And this was about 180 myeloma patients. And what was seen in this first study was when denosumab, which is the rank ligand inhibitor, was compared to zoledronic acid, there was a survival disadvantage for denosumab. So obviously one had to think long and hard as to why is it that the biology of rank ligand is so well explained in myeloma and yet you're seeing the survival disadvantage. We then went back and did a little bit of homework here, and we took back the MRC data, and when we looked at the MRC data, we saw that the MRC9 zoledronic acid arm actually overlays completely over the current trial's denosumab arm, and the zoledronic acid arm in this AMG study, in this rank ligand zoledronic acid arm, seemed to be the outlier, suggesting to us that there may be inherent differences in these two arms here. So we went back to look at those differences, and what we found was that patients who were getting denosumab were randomized, but nobody had control for things like renal failure. We all know that renal failure has an impact on survival. Fewer patients on denosumab actually ended up getting a autologous stem cell transplant. We also know that that can in fact impact outcomes in patients, and you had fewer patients with stage 1 disease in the denosumab arm. So essentially what we learned here was this was not a myeloma design trial, and nobody controlled for the factors which do impact the prognosis of myeloma patients and do impact the outcomes of myeloma patients, both in terms of disease control as well as overall survival. So we went ahead and designed this large trial, and I might add, outside of the first trial, this is in fact the largest myeloma randomized trial that we have. So it's about 1,700 patients who were randomized to denosumab versus zoledronic acid. And in this case, we took our instruction from the MRC9 trial, and we really controlled for these factors. So we controlled for anti-myeloma therapy, novel IMiD-based, proteasome inhibitor-based versus chemotherapy, whether they were getting an autologous transplant, disease stage, as well as we looked for the reason for Japan was only for regulatory purposes, no other purposes. And then they were randomized to get denosumab once a month versus zoledronic acid once a month. This study was designed as a non-inferiority study, and if you look at the rate of the primary endpoint, which was the proportion of patients without an SRE, there was really no difference between denosumab versus zoledronic acid. But this was a really important feature that we wanted to look at, which was overall survival, because what we had shown previously was an inferior overall survival, and thankfully in this study we did not see an increase in the number of deaths in the denosumab arm, which was really very reassuring to us. What came as a little bit of a surprise, and I don't think any of us was expecting this, was a progression-free survival benefit, and we saw a progression-free survival benefit of close to 11 months. I have never seen a PFS benefit of this big a difference in any myeloma trial to date. Most times we have all our drug approvals based on PFS benefit at most of 4, 5, 6 months maybe. So this was quite remarkable, and we are going back and trying to figure out exactly what this is. I do have my own hypotheses, but we have to confirm those data to see why we see this PFS benefit with denosumab. I think the most important other features from a myeloma standpoint are some of these. When you look at toxicities, and the most important toxicities in terms of renal toxicities, you saw a lot less renal dysfunction in patients with denosumab. Obviously, when you're using denosumab, given that it's a more potent anti-resorptive agent, you are going to see more hypocalcemia, and you are not going to see less osteonecrosis of the jaw. In fact, you might even see more, because this tends to be a more potent anti-resorptive agent. The obvious concern with most folks is, well, denosumab is a lot more expensive compared to zoledronic acid, and for that reason, we actually did a value-based analysis of the use of denosumab from a payer perspective, and we looked at a whole bunch of different costs. And I'm not going to go into the details of all of these, but sufficely to say that when you use a subcutaneous shot, which is an office procedure versus an IV infusion, and you take into account toxicity profile and benefit in terms of progression-free survival, we did not find denosumab to be more expensive. In fact, it was more cost-effective, and it was more value added using a drug like denosumab compared to zoledronic acid. I've shown you this slide already in a pictorial form. I'm showing you this again because, again, we continue to study the interactions of the tumor cell with the bone marrow microenvironment, specifically with the osteoclasts and the osteoblasts. This is a patient of mine who had a PET scan. He had mostly macrofocal disease, and if you look at his PET scan here, he had a lesion here, lesion here, lesion in the rib, lesion in the iliac wing, got just 3 cycles of RVD, and you see the PET has become completely negative. I'm just showing you this. This is the PET, and this is the scapular lesion, which has become completely PET negative after 3 cycles of RVD. But the point I want to make is show you this CAT scan here. This was the bone destruction in the scapula, and what you see after the myeloma has gone away is that osteolytic lesion is not filled up. If anything, it's a little bit bigger, and the reason I show you this is my lab is really focused on trying to see if we can change this bone marrow microenvironment to prevent seeding of these myeloma cells in the future. So we are studying a whole lot of things in addition to the interaction of myeloma cells with the osteoblasts. Along the way, we are studying mesenchymal stem cells, which we know are defective in myeloma, and we see that in myeloma patients, these mesenchymal stem cells preferentially differentiate towards the adipocytes compared to differentiating towards the osteoblasts. We've studied some of this in the lab before. We all know that proteasome inhibitors are in fact really good pro-osteoblastic growth factors. This was a model which we studied which did not contain myeloma, but we gave these animals low doses of Bortezomib, and in this case we saw increase in bone formation in these, and this data has now been shown in patients by Evangelos as well, wherein you see markers of bone formation increase with the use of treatment with bisphosphonates, and markers of osteoclast activation getting inhibited. This data is from Little Rock, Arkansas, this wherein Dr. Zangari showed very nicely on a bone marrow biopsy from a patient who was getting zoledronic acid alone, Bortezomib alone, no steroids at all, and on that bone marrow biopsy from a patient, he was able to show increased bone formation. So we know that certain myeloma drugs are able to increase bone formation. In addition to that, we've studied other factors, this one being Activin A. We know that Activin A actually increases or suppresses bone formation, and by targeting Activin A, we can change the circuit completely. We also know this Activin A is actually increased in patients with myeloma, specifically those with bone disease. And if you neutralize this Activin A, specifically in the context of IMiDs, which also increase things like Activin A as well as DKK1, you can actually reverse this effect. Based on this, we have an ongoing clinical trial which is run by Andrew Yee at my site, and he's shown very nicely for the first time now increase in bone mineral density, increase in biomarkers of bone formation, and with addition of that, we've also seen an advantage which can only be a benefit to our myeloma patients, wherein in the majority of responders, we've seen increase in hematocrits as well. We've seen markers of bone formation go up, and other markers of bone resorption like sclerostin go down, and we've seen PET scans become negative. Now, these were patients who were only getting lenalidomide and dexamethasone, no Velcade-based treatment, and none of them were getting a bisphosphonate. So this change in the DEXA scans as well as in the PET scan is largely because of sotatercept, which is the decoy receptor for activin A. What about other targets? We are very interested in sclerostin, and we know that sclerostin levels are increased in myeloma patients. We also know in preclinical models that by targeting sclerostin in combination, in this case with carfilzomib, we are actually able to reverse the effect of myeloma as well as cause increased bone formation. And in the future, we would really like to study this bone niche and combine anti-catabolics, so combine drugs like denosumab and zoledronic acid with some of these other bone anabolic agents, so that the CAT scan which I showed you, which shows increase in osteolysis, if we can block that and if we can make that heal, hopefully we are going to have better control of our myeloma. And along the way, we'd obviously like to see better imaging and biomarker tools as well. This is my group at MGH, and all of them contribute to taking care of our patients and doing all the clinical trials, some of which I've mentioned today. Thank you very much for your attention.